Right. So good morning and hello wherever you are. So thanks, Catherine, for the introduction. I'm going to be presenting briefly a broader program of research, which is called the South and Southeast Asia Community-Based Trials Network, for a couple of minutes. And then I'm going to hand over to Abhijit, who's going to talk specifically about a trial which was very much focused on a electronic clinical decision support tool. So, and the screen sharing's okay. Hopefully the slides have moved forward for you. Yeah. So briefly, the South and Southeast Asia Community-Based Trials Network. So this started out, it was about 6 or 7 years ago that the Wellcome Innovations team showed up at Moru and asked us if we had ideas for large, ambitious projects that could go out to hard-to-reach populations and really kind of try and have a measurable impact on global health, on health outcomes there. We proposed setting up a clinical research network that would be embedded within village health worker networks. Moru has direct access to several large such networks across the region, as do other collaborators in Bangladesh, in Myanmar, and elsewhere. And we just thought this was a fantastic opportunity to really go out and study what the causes of morbidity and mortality are in some of the more underserved remote populations in the region. But all of that was supposed to be directed towards the development and trialing and implementation of interventions that could improve health outcomes in these populations. Our focus was on improving the management of febrile illness. A lot of that was related to the fact that Moru for decades has been, as you all know, involved very much in understanding and developing malaria tools for malaria control and elimination. And as malaria transmission has declined across the region, it's become more and more of an issue to try and understand what it is when it's not malaria, what the causes of febrile illness might be, and perhaps more importantly, what tools might be of use in these challenging settings. So that was the main focus of the first 5 or so years of SEACTN, but we did have a kind of broader view as well in trying to understand other causes of morbidity and mortality. And I'll explain what I mean by that in a moment. This is just to give you an idea of the areas where we were operating and the scope, scale. So we had hundreds and hundreds of these village health workers embedded in villages across the region. We were also working in primary care centers and hospitals. This was a huge undertaking. We had to train up a lot of village health workers in the use of these tablets that you can see on the far right, which had the data collection tools built into them, how to collect dry blood spots and other specimens in the hospitals. So all of that was going on in all of the field sites. You can see the locations of the sites. There's actually a gaping hole in our plan. So we were also supposed to be operating in Myanmar, in northern Myanmar, in Kachin state. Unfortunately, we couldn't do that because of the civil strife in Myanmar. We also had a pandemic to contend with. So what was already a hugely ambitious, challenging project became even more challenging. Nonetheless, we were quite successful with it, and I'll come up to the numbers in a moment. But just to mention that within Moru headquarters in Bangkok, we also invested very heavily in building up our own capacity to run high throughput assays on what ended up being hundreds of thousands of specimens that came through, looking primarily focused on understanding the etiology of febrile illness, but also other causes of morbidity and mortality. So this is just some of the fancy gizmos, machinery we had to put in place. In the center of it all, you can see this is a device to process the dry blood spots. That alone was almost $100,000, I think, of investment. And that allowed us to process all the DBS, to punch them all, and then send them out to all the different labs where we're doing things like looking at biomarkers that might either predict severity or help diagnose the cause of illness, molecular assays, serology assays, all of which were developed from scratch. So, like I said, very ambitious undertaking. And the numbers were indeed impressive. We haven't actually got a lot of the final results, but just the numbers of patients that we did manage to recruit. So almost 100,000 febrile patients in these very remote community settings. So these were recruited primarily by village health workers. We also recruited approximately 7,000 patients in high-level health facilities where we could collect a lot more specimen. And these were generally patients who were also more severely ill. So in some ways, perhaps the more interesting end in terms of the severity scale. We carried out verbal autopsies. So that was another project where we investigated causes of death in 3,000, almost 3,500 individuals across the region, household surveys to understand things like seroprevalence, so exposure to different pathogens, but also looking at other NCDs and health status in other ways. Spot sepsis was another project embedded within the same program where we were focused very much on looking at biomarkers that might predict severe outcome in children with a febrile illness. And I'll mention later some of the outcomes of this, which are, we're hoping, will drive the development of new interventions and trialing of these interventions in our network. And lastly, we also managed to squeeze in, although the first 5 years were supposed to be mostly observational, we did manage to run our first intervention trial, which was very much focused on the development of a decision support tool supplemented with CRP testing and pulse oximetry. So to give you a little bit more details about the EDAM trial, I'm going to hand over to my colleague Abhijit, who's going to talk about that, and then I'll wrap up later with some more ideas about where all of this might be heading. Okay, Abhijit, over to you.
Thank you. And I'd also like to take this opportunity to thank Catherine and Yael for inviting me to speak on this EDAM project, our project. So to give you a little bit of context, I'll start with the background of what the situation is about the febrile illness in Cambodian setup. So it's one of the most common presentation in primary health centers in Cambodia as well as in South and Southeast Asia. And traditionally, malaria was thought to be the most common cause of fever. But thanks to the novel RDT, these numbers have reduced significantly. And this has caused the researchers to shift their focus to other infectious diseases, such as respiratory infections, being one of the most common other infectious disease causing fever. But the challenge is semi-skilled healthcare workers who lack diagnostic tools and clinical skills. So this causes inappropriate prescriptions of antibiotic, which is one of the major problems causing antimicrobial resistance in this area. So this created a gap after malaria out of picture. So researchers decided to come up with an app which can fill the gap. And this app was to optimize acute febrile illness in Cambodian setup, which we called EDAM, which is Electronic Clinical Decision Support Algorithm for the Management of Acute Febrile Illness. Let me take you through how this app works. First of all, the patient presents to the primary health center, and then these patients are screened based on the app, where they put healthcare workers feed in the information such as demographics. And after the screening process and the enrollment criteria such as fever for at the time of presentation and fever in the past 24 hours, and if they are aged 1 year and above, and their acute presentation, they will be enrolled. After enrollment, the app suggests another special and most important criteria, that is danger sign, which is measured or observed danger signs. These measured danger signs being vitals, respiratory rate, heart rate, blood pressure, pulse oximetry, and observed danger signs such as seizures and dehydration. After these information are fed in by the healthcare workers, another section comes in the app, that is the symptoms, where the healthcare workers ask the symptoms to the patient, and those information are fed in the app again, which then guides the healthcare workers to perform malaria test and rapid diagnostic malaria test and CRP test, or just the malaria test. And after those tests, the results are fed in the app, and then the healthcare workers gets the management plan, the diagnosis and the treatment plan. After this diagnosis and the treatment plan, the healthcare workers have full autonomy to whether follow the app or to just say, no, I want to give my own treatment and management plan. And then the next section comes where the healthcare workers take consent basically from the participant for being followed up on the 7th and the 14th day. And we have a dedicated group of researchers who conduct this follow-up on the 7th and 14th day. Yes. So the main objective, that was the overview of the app, how it works in the real setup. So the main objective of our study was to know the percentage of patients with acute fever who were prescribed antibiotics. And there were some secondary objectives, like to compare the clinical outcome between the EDAM guided approach and the routine care approach, and also to evaluate if the healthcare workers agreed with the EDAM's approach. So this EDAM study design, it is a pragmatic cluster randomized controlled trial where we had cluster of 30 health centers from 3 different operational districts, which were randomized into 15 intervention arms and 15 routine care or control arms. And yes, the study population were similar in both the arms, intervention and control arm, with the mean age being 17 years. And the most proportion of patients were from the age group of 5 to 14 years, with female percentage being high, and almost similar percentage from all the operation district. And study populations were kind of similar in both the intervention and the control arm. In terms of danger signs, the patient presented with the danger signs were nominal, just 5%. And the most common symptom at the time of enrollment by organ system was respiratory illness, followed by gastrointestinal, ear, nose, throat, skin, soft tissue, muscular, skeleton, and urinary tract infections. So the results, the primary outcome of result, you can see the primary outcome to know the percentage of patient who were actually prescribed antibiotics was 56.1% in the intervention arm, whereas in control arm it was 60.5%, which actually has no statistical importance in the difference of both these arms. The secondary outcomes, where we looked at the percentage of the patient referred to hospital at the time of presentation, which was almost similar in both the arms, up to 2%. Full recovery at 7th day was almost similar in both the arms. And severe outcomes by day 7 was 10 and 9 patients in intervention and control arm. So this also showed no difference in clinical outcomes in patients in intervention and control arm. Looking at another secondary outcome, that is proportion of patients where healthcare workers agreed with the recommended management plan. You can see half of the patients over here still got the antibiotics, whereas it was not recommended. And going further below over here, you can see the hospital referral recommendation, which is just 25 patients were recommended, 25 patients were referred, whereas 376 were recommended by the app. This could be just because of the approach by which these referrals were made by the app, and healthcare workers did not agree. They used their own clinical skill to judge and not refer the patient. Another topic for today is usability and acceptability. We used the questionnaires based on mHealth app usability questionnaires, which is a reliable way to measure usability of the mobile mobile health interventions. And we adapted local contextual adaptations were done, and our specific research questions were also taken care of, which was, for example, perceived EDEM app perceived thought about how it works and the management plans, and decreased antibiotic use, whereas also we explored more on the healthcare workers' approach of overriding the recommendations. There were different questions, 8 questions on usability, 8 on acceptability, and few free text questions where we could understand their views. And we also did focused group discussions. These questionnaires were done on 45 healthcare workers from the intervention arm, which is 15 primary health centers. And also the focus group discussion was done in diverse mix of health professional, that is staff nurse, midwives, and health center managers with various clinical experience that ranged from 2 to 37 years. The usability result, you can see the dark green, which says strongly agree, and you can see the improvement post-trial, you can the darker green lines. The only difference was in the question 1G and 1H, where the healthcare workers disagreed strongly. 1G is the question about the time constraint, time needed to complete the consultation, and 1H is the question about if they could quickly go back and correct their mistake once they have entered the information in the app. The acceptability result, you can see the dark green, which is again the strongly agree part. Post-trial, the improvement, general improvement in the acceptability is seen post-trial. Overall impression, you can see almost more than half of the patients said they were satisfied by the EDEM app. The focused group discussions results, the general complaint from the participants was that patients become very impatient when they have to wait in the queue, and this leads to tension and dissatisfaction from the patient. Other discussions which was important was the fever. Fever was the most common presentation in these setups, with the patients being under 5 years, and they used IMCI and local guidelines for the treatment. They also iterated that benefits of EDEM app was a lot, especially in the primary health centers, and they also praised that it actually helped them to diagnose more accurately and limit the antibiotic use where it's not necessary. The one concern they usually reported was that the symptoms, rather I would say, the incomplete symptoms or limited symptom list, which led to rather cautious diagnosis, or inappropriate diagnosis and referrals. Technical issues, they said it's very user-friendly and it was easy to use, and overall they said it has helped them a lot. The recurrent suggestions from healthcare workers was the symptom list and the diagnosis was limited, and they wanted a approach where the variety of patients could be diagnosed and treated. The next topic is lessons from the field, which the methods which we used was mixed method approach, and we did structured observation. We collected data from pre and post-trial surveys and also from the structured observations in 12 different primary health centers. The main challenge which came out was time constraint. It took them almost 33 minutes to complete the consultation with the in the intervention arm, which is also doing CRP test and malaria test, which takes 20 minutes to complete. And this was complicated by high patient volumes, especially on Mondays and Fridays, where there were 50 patients, which led to rushed consultation. Another challenge was binary symptom questions. Binary symptom question, basically yes/no questions, where healthcare workers struggle. Especially imagine on a busy day, 50 patients waiting for the queue, and then the chance comes and frustrated healthcare worker asking vomiting or lethargy questions, and the answer is going to be just yes or no, no deeper digging. So that was another challenge where we have to think about nuanced questioning and additional training approach. There were a few contextual challenges like technological barriers. We saw that in some of the primary health centers, the recruitment was slow, especially if the healthcare worker is not familiar with the modern gadgets. Also, the patient follow-up, Cambodia, here in rural population, they are mostly, they mostly rely on the forest, and they are traveling in the forest most of the time in the day. So it was hard for us to communicate during the follow-ups. And also most of the patients rely on one family member for telecommunications, which also posed another problem for patient follow-up. However, we mitigated the loss of follow-up by collaborating with the village level healthcare workers and village leaders. Other environmental factor, Cambodia being the tropical and hot and humid country, afternoons become really very hot, and that decreases the patient's attendance. Also, in the rainy season, the muddy roads get flooded easily and is difficult to travel, and that also decreases the enrollments. Staff shortages. We trained 3 healthcare workers in each primary health center, but they also had different roles in the community, such as going for vaccinations, doing outreach programs, also were involved in administrative works, tasks, meetings. So this created a staff shortage, which also was one of the challenges in case of completing consultations. The main important part of the topic, lessons learned. So it is important to develop a clinical health tool which is user-centered, and it aligns with the daily routine of the healthcare workers. And also we have to keep in mind about their clinical skills and capabilities. And also the pre-trial training and the feedback received during the training is also essential. Another part is the stakeholders engagement. We conducted regular field visits with the provincial health department representatives, which also motivated the healthcare workers. Also, we collaborated with the local NGO called HIGHQ, and which facilitated follow-ups. Also, we need to balance efficiency and comprehensiveness. Streamlining algorithm or adding offline functionality to reduce time burden. As you can see, it's one of the major challenges for the healthcare workers in rural Cambodian population at the time. Also, adapting to the intervention to local context is important. As I mentioned, staff shortage, environmental factor, and technological literacy, these all should be taken care of when we are developing these kind of tools. Digital health interventions are newer for the modern medicine, and actually it's rare in the low middle income country context. So conducting such type of trial is really difficult and it's filled with challenges. However, EDAM showed promise in optimizing fever management, but it also revealed many challenges and issues. So I hope with this experience with EDAM and lessons that we learned will help the researchers guide researchers and policymakers in developing digital health solutions for low middle income country healthcare workers in limited resource. Thank you.
Thanks, Abhijit. Yeah, so just to fill in one more little piece of information as to how we use the observational work to design the EDAM app, I think it's just important to add. So our colleague Chris Chu, he did some really nice work taking a lot of the data from SEACTN, from the observational work, where we had a wealth of data from almost, like I said, over 90,000 patients, where we had all the clinical symptoms. And then with a panel of experts, there was a consensus as to how we assign different symptoms to a syndrome. And then that informed what the algorithm would recommend in terms of patient management. So most importantly, perhaps whether or not antibiotics were required. So that's already, I think, potentially a big step forward in terms of the development of these algorithms. But we are hoping to draw on a lot more data that's going to come out of SEACTN. Specifically, we're very keen on the use of point-of-care biomarker tests, but also the etiology data that will help us to further refine these algorithms. So I'll come back to that in just a moment. But just to say in general, so next steps, we still have probably 1 or 2 years worth of work in terms of analyzing all the data, the samples we have. This is going to end up being the largest, as far as I know, the largest ever description of causes of febrile illness in LMIC settings. We're going to try and do a lot in terms of using that data in terms of various prediction models, predicting outbreaks, linking it up with environmental data and so on, to map out disease distribution in relation to various risk factors. We've already started doing some interesting proteomic, and we'll be doing transcriptomic data as well, analyses as well, to look at signatures that might predict either severity or diagnoses, and then look at ways whereby we might be able to integrate this later into patient management tools with various appropriate point-of-care tests. We're doing a lot of work now. We've got a sub-study, which I think is really interesting. It's called CARAF, and that is doing antibody kinetic profiling. So for all of the key pathogens in the region, so that we are better able to interpret the serology tests. So both to carry out things like seroprevalence surveys, so it's to understand what it actually means when we see different levels of apparent exposure from the assays, but also it would enable us to actually make much better use of serology point-of-care tests, which are fairly widely available, but we often just don't know how to interpret their results in the context of patient management. And there's some work which hopefully will be led by another colleague, Elke Weinberg, looking at the long-term follow-up to try and quantify the sequelae that's associated with different infections are common in the region. And last, not least, perhaps most relevant to this webinar, is the development of AI or machine learning-based clinical decision support tools, drawing on all of the different data that I just mentioned, whether it's clinical, etiological, biomarkers, and so on, and bringing it all together into the development of more advanced algorithms than the ones that we've been using so far in EDAM. So this is going to be the focus of a PhD, a DPhil project, which has just started, is now underway as well. That's led by Abdullah Said Khan. So just to come back for a moment, there's the electronic decision support tools, which are one critical piece of these interventions, and then there's the actual point of care tests. I mentioned spot sepsis, where we're getting a lot of biomarker data to say which ones best predict severe outcomes or specific diseases. We've already started collaborating with a manufacturer of point of care tests, and they've used the outputs of spot sepsis to design a multiplex biomarker assay, which we will now be doing some validation work with them. And that, we hope, will be integrated with the electronic decision support tools. So these biomarkers might be able to assist both in identifying when patients might benefit from antibiotics, and also when it is most appropriate to simply refer them higher up to higher level facilities from these more remote settings. In the long term, we are hopeful that Wellcome will continue the funding so that we can gradually transition and do more intervention studies, drawing all the work we have done, the observational studies, although we do want to carry on the observational work as well. So we have a kind of continuous feedback loop in terms of interventions that we think can have an impact, but also carry on refining the interventions based on what we see on the ground in the ongoing different forms of surveillance, syndromic and etiological. We should hear back from Wellcome, we hope, next month as to whether or not there's going to be funding to support all of this. So that was all I was going to say. There's some acknowledgements here specific to the EDAM study, which involved a fairly large team. And what I haven't even tried to list out is the massive, wonderful team that we had involved in running all of the SEACTN program across the region. So I'm really thankful to all of those individuals, but that is too long a list to list out. Thank you very much. Back to you, Catherine. I think we're taking questions at the end, or I can answer any now.
Great. Thank you so much, Yol and Abhijit. If anybody has any questions, please put them in the chat or save them to the end. And Chan, I will pass it over to you.
Sorry, can you hear me?
Yes, we can.
Okay, this is my slide. Okay.
Yes, they just not in full screen though.
Okay. So hi, so thanks, Catherine. Okay. So hi everyone. My name is Chanh. I'm a pediatrician from Vietnam and currently based at the dengue research group at HIGHQ Ho Chi Minh City. And very happy to be here today to share with you some of our journeys in developing a clinical disease support system for dengue in Vietnam. And it's quite contrast to the reverse talk. So it's more about the hospital settings and for a specific disease like dengue. And so for this talk, I will first introduce about the context and the problems that we face, and then move into what we did and with some of the final discussion about the lessons and the result. And so first about to introduce you about the disease. So dengue is a viral infection. It's affected the tropical countries like Vietnam, and actually at 40% of the global population are at risk of the disease. The incidence of the disease increased rapidly for the last 10 years. So the WHO had put the disease into one of the 10 threats of the global health. It's now spreading to the new areas like Nepal or southern European countries like Italy and France. So in Vietnam and also other endemic countries, so dengue is one of the leading cause of the hospital admissions. And you can see in the slide the photos of the both outpatient settings and also the hospitals in Ho Chi Minh City. We don't have enough space for the patients, so we need to put more beds at the corridor for them. And every 3 or 4 years, there will be a new outbreak. But due to the climate change and all of the other factors, so the outbreak becomes more severe. For example, in Brazil, they have persistent outbreak for the last 2 years, and they have millions of people with dengue now. And moving a bit more about the disease, so it is a acute disease with a broad clinical spectrum from mild febrile illnesses to very severe complications, potential life-threatening conditions like shock. And until now, there is no effective vaccines or treatment for the disease. So the way we manage the patients is relying mainly on the close monitoring to early identify the severe patient. So you can see on the slide is the unit course of the disease. So the severe complication usually occurs during the critical phase, around day 4 to day 6 of the illness. So we hope that we can always identify the patient who are going to progress to severe disease during the first 3 days, and it's quite tricky actually. And to sum up with some of the challenges we face in clinical management for dengue, is about the management is hard because of we don't have reliable things to identify the severe patient, and it lead to the admit all of the patient into the hospital so we can hope that we can identify the severe patient earlier and to provide timely interventions. And these are the photos of the severe patient admitted to the hospital. During the outbreak, all of the ICUs in the hospital are filled with dengue patients, and we don't have enough resources for all of the patients actually. So with these challenges, under the Vital project, also funded by Welcome, the dengue group at HIGHQ, we utilize the digital technologies to try to solve the problems by developing a specific wearable device for dengue called the SCAP, and also together with other podcast tests. And finally, it's to developing a clinical disease support system for dengue. All of these applications can be used separately, but also can be used together under the clinical disease support system platform. And I have summarized what we did for the last 5 years in the publications from for who. And if you're interested in it, you can scan the QR code to read more. And now I will focus more on the clinical decision support system for dengue that we developed. So we use Hospital for Tropical Diseases in Ho Chi Minh City as place to develop, and because it's the main working state of us. And also the system had been built with the aim to make the treatment and the management of the patient more efficiently, and also improve the decision-making quality regardless of the clinical experience. And we call it the CAT, Dengue Clinical Assessment Tool. So we team up with the Imperial College London to develop the tool, and we leverage the experience from Imperial team with the EPIC Import is the decision support tool for AMR, and we try to develop machine learning models to embed it in the CDSS. And also we take the human central design approach to develop the tool. So it's could maximize the uptake in the future, and also it's designed with the modules so it can easily drop and add more functions if needed. And here are the workflow to develop the tool. So there are two main components working in parallel. So the first one focus on the data models and also the system development. And the second work package is about to understand the settings to perspective and also to the regulations at Vietnam for the tour, and the work lasts for 5 years, and we'll talk more detail in a minute. So first, I briefly introduce about the data and the algorithms that we developed during this project, and they and Berna from Imperials are also working in this work. So for this clinical decision support system, the
Jen, I think you might be frozen. Sorry, everyone. I think we lost him for a second. We'll just give him a minute to sign back in. Great, you're back.
very sorry. My connection is not stable. Yeah.
Maybe do you want to turn off your video? That might help.
Okay, yeah, sure. Okay. So for the risk prediction models, we leverage the pool data sets from our research group for the last 20 years, more than 4,000 patients with dengue to test different machine learning models focus on the widely available parameters in the routine care for dengue patients to develop the models, because it could help to maximize the information in the future. And we test with several machine learning models, and finally artificial neural networks have the best performance. So we use this model to embed it in our decision support system tool. And with our models, the strengths would lies on the existing data in our group. We routinely collect for all of the patients over time. So it represents for the dengue patients in Vietnam. And also we only use the importance variables available in a clinical management for the patient. And so it does not require extra tests or limit the use of the model in lower settings. However, we're also aware that we use prospective pool data. So in the future, we also want to conduct a prospective study to validate the findings. And also we try to use test the model in other populations outside Vietnam, so we can make sure that it's work well with other settings, especially when where the demographics and the dengue virus circulation will be different. And for the and algorithms, it's important to have good accuracy as well as also accept the models. And finally, we also think that it's really important to explore the usability because it's good in the clinical settings. And we so with this one, I moved to the
Sorry, everyone. I think we lost Chan again. Let's just give him a second to rejoin. Oh, there he is.
diseases is one of the main hospital admitting dengue patient for the South Vietnam. And so dengue account for a third of the hospital admission. And every year we have more than 5,000 severe dengue in the ICU. Sorry.
Oh, we lost your slides, I think.
Okay. So if we follow sequential step in order to develop the tool that we think that could be a decision support system. And so we start first with process mapping. We try to visualize the whole workflow of dengue management at the hospital. And one of our colleagues, Dr. Hui, observed the patient at the time that they arrive at the hospital and throughout their hospitalization. And for this one, we found that because at the hospital tropical diseases is both for the adult and children, so it's quite mixed settings. And we've identified that for the pediatric and adult patient, they follow different care pathway, and it's important for the staff to remember the flow of the patient in order to have appropriate management. And we find that there are 4 key main points during the process. where the doctors and nurses need to make decisions for the patient. And for example, at admission, they need to make decisions regarding the patient severity, status, and then the care pathway they need to follow. And during the management, it could be about make decisions regarding the whether the patient need to escalate care or they balance between the risk and the benefit of any treatment they provide to the patient. And with these key points, we continue breaking down the tasks that the staff need to do for all of the patients. And by doing this one, we hope that we can by the introducing of clinical decision support systems, we can reduce the time required for all of these procedures. Okay, sorry. With the fluid management, fluid calculation, we can reduce the time of to do for every patient with shock. And moving next, we continue with the interview for the doctors at the Hospital for Tropical Diseases. For these particular things, we want to explore the perspective of the healthcare workers regarding the dengue management and identify potential needs from them. So with the 10 interview conducted by Huy and Ang, we identify their main themes emerging from the dengue management. So first is regarding about the clinical examinations. So it's always the key information to make decisions. And also there are barriers in terms of diagnostics for dengue patient in Vietnam, even it's a very common disease. And the next themes regarding the guidelines. So in Vietnam, the guidelines for the disease, for management any disease, is not only serve a additional scientific tool, but also it serves a legal and regulatory factors when we make decision to treat patient. And the next theme would be about external factors that can affect how they make decisions for the patient. Especially it's about the seasonality, the dengue seasons during the year, and also the increasing number of patients when they need to manage. Finally, it's about the use of additional tool to support them clinical management. And for more information, you can read in the paper. And building from these 5 themes, we conducted 2 group discussion to identify the potential functions that can have the hospital staff, and also to ask for their feedback to optimize the tool. So in the first workshop, we identify several functions that the hospital staff would like to have, and also characteristic for these function. And we work together to characterize these functions in terms of the complexity and also usefulness. And because of the limited resources, so we focus more on the least complex and most useful categories to for the final clinical decision support system. And it consists of something similar to the electronic medical record, guidelines, and fluid calculators or risk prediction models to help them make decisions in terms of the patient's management, and also serve as a tool to document the disease at when they discharge. And with the clinical, with these core functions, we developed the draft prototype for the tool, and I can quickly show you with the videos. This quite basic tool, and it's a web-based to maximize the use. So we have the patient list here with the color one represent the risk of the patient. And we embedded the guidelines I requested from the staff because it's really important for them to always refer back to the guideline during manage or make decisions for the patient. And another one is to calculate the weight for the patient to provide the IV fluid infusion. And for this one, important for the junior staff because usually they need to spend more than 10 minutes to calculate the dose as the second workshop, and also 50 individual testing for the doctors to ask for fixing. They really excited about the tool, but they always ask for more parameters to use clinically, and also with regarding the algorithms, because we think that we develop with the widely available refer to have more predictors in the models, and they think that with the normal parameters, the model couldn't beat them in terms of the accuracy. Point for them to use the tool is that the automatic automation, if they need to manually enter the data to the tool to use, they will not use it because it increases the workload for them rather than reduce save time from them. And they also have some of the comments regarding the visualizations and the arrangement for easier navigate when using the tool. And at the end of the projects, we also do a little bit of exploring the regulatory landscape in Vietnam for short tour. And at that time, there are two key important documents for the tour. So it defines that software is regulated as a medical device. And they also say quite openly about having the international approvals from the big countries like US or UK could also make the approvals a little bit easier. And the second documents which was imposed also add more detail in terms of classifying the risk of the medical device. However, also no update in terms of how to regulate software as a medical device in Vietnam. And the project finished in 2023, and because of its potential use in clinical practice, in our group, we plan to continue our work in the future, focusing on refining the applications, and then you implement in the lower level hospital, because for this type tool, it's always the end user always the lower level hospital. And also we will do more proper regulatory landscape explorations and engagement with the public and also the government to maximize the uptake and get the approval to use in clinical practice. And we have, it has been a quiet journey, and there are lots of lessons that we learned during the process. So there are 4 key points that I want to share today. It's about it's really important to understand the settings and also the think about the usability when you develop the tool, the algorithms, rather than a way to at the end to do it. And also, it requires a lot of effort from different people from different fields to develop a medical tool like this one. And it's really hard to have all of the expertise in the low middle income countries like Vietnam. Um, um, but if you think about it, so it may require time for you to plan how to recruit all of these people into your team. And the next one is about around the trust, the acceptability, and in Vietnam, it is especially important for you to have the regulatory legal safeguard to use digital technologies in the clinical settings. And finally, it's about the literacy and readiness of the system and also the user for this kind of technologies. And when we first we developed this one, we think that we can extract the data from the medical device and fit into our tool, similar to the UK. But when we in the middle of the journey, we found that actually we still have a lot of issues regarding the regulations and also the infrastructure to do so. And with that, I will stop, and I would like to thank to our colleagues at Oxford, Imperial, and Oxford, as well as the hospital staff who are participated in our work.